It's really just a tremendous pleasure and an honor, really, to welcome you on behalf of the Department of Population Health here at the New York University School of Medicine to our second annual Health and Conference.
So it's a really important question, how we mitigate and I hope eventually dismantle the impact of racism on health. And it's a big question. It's one that belongs not only to public health or healthcare delivery, but to our whole society. But there are a couple of things that we can do in public health that we should routinely do. One is to always use a racial equity lens and when we look at our data, when we plan our interventions. Another is to increase our focus on racism as a determinant of health, because very often we talk about social determinants of health and we don't even mention race, even though there are reams and reams of data to show the enduring, long-standing impact of race on health.
Doctors can play a big role in addressing racism and health inequities by first acknowledging that racism does impact health. And then they can start by examining their own behavior to make sure that every time we encounter a patient, that we're treating them with the same care and respect with which we treat everyone else. Making sure that we administer equal treatment to everyone, regardless of what they look like. Then also understanding that it goes well beyond what we can do as a doctor to one patient. We have to look to higher levels. We have to look at structural racism and think about how we can contribute to dismantling structural racism that results in suboptimal housing conditions, that results in lack of insurance coverage to really enable people to live their healthiest possible lives.
What strikes you as really a top priority in improving health equity in the United States today?
First, we have to make sure that there's a health equity lens on public policy. If 20 million people lose health insurance, that will be devastating for health equity. Second, we have to look at specific programs, particularly the prevention of heart disease and stroke. That's the leading driver of health inequalities in this country. We need to make much more progress, and we can.
So I think the healthcare sector can be most effective by partnering directly with the providers of assisted housing to reach the tenants. So if you look at federally assisted housing, 70% of the seniors in that housing are duly enrolled in Medicaid and Medicare and a very high cost, high need population. Federally assisted housing has more than 4 million children in it. 28% of poor children of color in this country are in federally assisted housing. 58% of poor African American kids. So if you partner directly with the housing providers, you can reach those seniors, the families, the kids, before they develop the types of conditions and outcomes that bring them into the formal healthcare system. There's been a lot of discussion today about how do you reach earlier, because interventions earlier are more effective, more cost effective. Go where they live, go to their housing.
What we're trying to do at this conference and in population health in general is recognize that the causes of poor health are really an interplay of many aspects of how we live and how our communities are run, how we interact with each other, how we live, eat, and play. And so we are in healthcare at an academic medical center, but we actually have to work in partnership with our partners in health and in education and in the communities to find really how we can address these true causes of disease.